A warm good afternoon to one and all. It is a pleasant day to host another webinar, and TMAS takes pride in it. Today, we have pediatric hematopoietic stem cell transplantation taken by Dr. Deepthi Sachin, chaired by Dr. Mohandos Murgese. Dr. Mohandos Murgese, a man who needs no introduction. Sir is currently the additional professor in the Department of Transfusion Medicine at Malabar Cancer Center, Talashiri. He is also District Nodal Officer of Blood Transfusion Services, Kannur District. He is a recipient of Young Scientist Award, ISTM TransMedCon 2020, and also a member of ISTM, ISBTI, ISBT, and he has 21 publications. His areas of interest are apheresis, flow cytometry, research in transfusion medicine, graft engineering, etc. I humbly welcome you, sir, to introduce Dr. Deepthi Sachin and to chair this session.
Good afternoon, all. First, I would like to thank the Executive Committee of TMAS as well as the Scientific Committee for this opportunity. So I'm indeed very happy to introduce today's speaker. It's Dr. Deepthi Sachin. Madam is a senior consultant and clinical lead from the Department of Transfusion Medicine, Dr. Rela Institute of Medical Center, Chennai. She did her MD Transfusion Medicine as well as PDCC from SGPGI-MS, Lucknow. Presently, she is the Joint Secretary of the Indian Society of Transfusion Medicine. She is also an NABH assessor for the blood banks and has a vast experience of 15 years. She is a member of ISBTI, ISTM, ISBT, ATOM, ISHI, ILTS, and ASFA. So she has received multiple awards. One of the few major highlights of her work, she was an Young Investigator Award in International Congress of ILTS this year at Netherlands. Dr. Usha Gupta Award in TransCon 2020 and held in February 2021. And Young Scientist Award runner-up in TransMedCon 2015. HD Shore Award in TransCon 2014, Harold Gunson Fellowship, ISBT 2013, and she has numerous publications to her credit. Her key areas of interest is patient blood management in solid organ transplants, advanced immunohematology, therapeutic apheresis in liver disease, stem cell collections, HLA and transplant immunology, and quality and accreditation. So I welcome you, ma'am, for this topic. The session is yours.
Thank you, Dr. Mohan. First of all, I would like to congratulate Transfusion Medicine Academic Society for conducting these webinars and workshops and definitely doing a wonderful job for the transfusion medicine patients as well as the PGs. And I would like to thank for giving me this opportunity. And I'll try to share the screen now. Is it visible?
Yes, ma'am, it is visible.
So today the topic I will be talking is pediatric hematopoietic stem cell transplantation, transfusion medicine perspectives. An important talk because we being transfusion specialists and working on different type of cells, hematopoietic stem cells are definitely an important area. So hematopoietic stem cells, we all are aware these cells are special with the capability of self-renewal as well as they can differentiate into different lineages. And with this capacity, this hematopoietic stem cell transplants actually help in treatment of various conditions where they bridge the procedures for hematopoietic rescue whenever the patient goes for chemo or radiotherapy. It helps in re-establishing the hematopoietic function in patients whenever they have any defective or damaged bone marrow or immune system dysfunctions. And various kind of disorders are there in which it is approved as a treatment modality. So for any conditions, for us, it is important to know the important milestones. So for bone marrow transplant or hematopoietic stem cell transplant, the efforts were being tried from the World War II time when the skin transplants, and these were not getting success. And on the patients who were having this exposure of radiations and all, initially 1957, it was found that marrow can be safely infused. And Dr. Donald Thomas first did the successful identical twin transplant in 1958. At that time, actually, HLA typing was not yet, and after 58 only it was started. So later on, once the HLA typing started, slowly with the help of that, related donor transplants using bone marrow harvest was perfected in 1970s, and various reports on leukemias, successful transplants were reported. After that, peripheral blood stem cell harvest initially in 1989, and then the cord blood transplant in 1990. And during that time, the effort started for unrelated transplants. And then in 1996, for older patients or with patients with comorbid conditions, partial myeloablative or non-ablative transplant started. And further, as the chances of full match transplants were less, the chances of half match on haploidentical transplants, and like that, there are many further advancements happen in this field. If we talk about India, the first transplant happened in 1983 in Mumbai. And with this, we can see in last almost 38 years, there has been a significant increase in number of cases. And now we can see almost 2,500 transplants are happening every year, and with the increasing numbers. So how pediatric transplants are different from adult transplant? Children do have unique entities like neuroblastoma, germ cell tumors, hemoglobinopathies, congenital immunodeficiencies, or inborn error of metabolism for which they require transplant. Although there are various indications like leukemias, lymphomas, aplastic anemia, which are common, and both adults and children may require transplant. This set of patients are unique because they require expertise both in stem cell transplant as well as managing these pediatric patients. And definitely they need to have a long life expectancy and so that the expertise is required in pediatric transplant. We all are aware that there can be transplants can be autologous, where the patient's own stem cells are collected and preserved, and then the patient goes with the disease-related chemotherapy or radiation, and that same stem cells are infused back, and which helps in the treatment. While an allogenic, another HLA matched donor can donate stem cells, and which helps in the transplant. In related or allogenic transplants, it can be from the identical twin, which is also known as syngenic, while match-related donors are usually full match or one allele mismatch. Nowadays, as the chances of having full match are less, maybe 30% in a family, so the number of cases of haploidentical are increasing, where even the parents or first-degree relatives can donate if they have one haplotype match. And again, the unrelated donors match transplants are increasing, so that is also one category where the transplants are happening. So if we see again the data from India, both allogenic and autologous transplants. Allogenic transplants are almost 60% in numbers, and 40% are autologous. The sources of stem cells, we all are aware, it can be bone marrow or peripheral cord blood or cord blood. Peripheral blood stem cells are simpler method. It can be even done in the outpatient basis. The stem cell content is better. The chances of infections or the risk of malignant cell contaminations are less. Engraftment is faster, and there is no need for general anesthesia or the no discomfort which happens in the bone marrow aspiration. So this is a preferred method nowadays. Mostly peripheral stem cell collections we are seeing. If we see this report again, till early 2000s, it was mostly match-related donors in allogenic transplants. However, the haplotransplants are increasing in number, and the matched unrelated donors. There are various registries internationally and nationally, which are number of donors who are voluntarily registering, and they are coming up and the collections are increasing. Almost, if we see that the haplo cases are 33%, and if unrelated donors are 10 to 11% cases are donating for the stem cell transplants. If we see the transplant indications in pediatric, in Indian scenario, it is almost 1/3 cases are pediatric, where major indications are hemoglobinopathies like thalassemia, cancers near ALL, or acute myeloid leukemia, Hodgkin's lymphoma, primary immunodeficiency syndromes, solid tumors, CML, and other solid tumors, which are the common indications. Again, the allogenic and autologous indications will be differing, where pediatric allogenic will have the maximum numbers are thalassemia or the ALL, AML cases, or severe aplastic anemia, while in autologous, mostly we see the solid tumors or germ cell tumor, Hodgkin's lymphoma, where autologous transplants are happening. Our center, we have completed around 106 transplants, where the maximum number of cases are thalassemia major are done, which is almost above 50% cases of hemoglobinopathies. Other indications are bone marrow failure cases or hematological malignancies, immunodeficiency syndromes, solid tumors, or metabolic disorders. Coming to the important part of the topic, that what is our role in this hematopoietic stem cell transplant as a center. Apart from collecting stem cells, there's a very important role that to provide them specialized or modified blood components, to monitor the platelet refractoriness and manage it if required. There is a need of strong immunohematology laboratory to monitor if the patient is aluminized or patient's titers or Coombs test. These facilities should be there. And again, many of these cases may require therapeutic apheresis facility. So that also plays an important role wherever the BMT programs are going on. If we see that the transfusion support in oncology or stem cell patients, these patients are actually requiring long-term support because they undergo cytopenias and they are on regular red cell or platelet transfusions. Patients are immunosuppressed, so they are at higher risk of transfusion-transmitted CMV and other viral infections. They're at risk of GVHD. Many of these patients can be HLA aluminized, red cell aluminized because of multiple transfusions. These stem cell transplants may have AV incompatibility involved. They may have platelet refractoriness, and many of these patients, because of multiple transfusions, may have reactions. So the facility or the blood centers need to have leukoreduced components so that the risk of infections are reduced. And almost for CMV negative products nowadays, mostly leukoreduced components are used. Irradiated cellular components are important to prevent GVHD, and it is a very important entity that to prevent GVHD in all the transplants once planned up to almost 6 months or till the patients are out of immunosuppressions, irradiated products are required. Antigen matched blood, platelets with additive solutions, leukoreduced products. If the patient has refractoriness, either the requirement of platelet cross-matched platelets or HLA matched collections, many of these cases may require granulocyte collections or donor lymphocyte infusions. So these facilities are important facilities, and actually each topic might be a separate topic to discuss, but yes, it is an important part. Coming to the next is donor evaluation. So in like how we do in whole blood or the platelet collections, donor evaluation is very important for stem cell donor, be it autologous or allogenic donor. So in autologous patients, more important is whether they are eligible for transplant, their fitness, whether there is any residual malignancy, or how is the bone marrow cellularity, whether they are eligible for transplant is an important question. While in allogenic, the degree of HLA match, ABO incompatibility, and their fitness for donation is important. So it involves the medical history, about their vaccination, surgeries, previous donations, physical examination, their microbiology screening, which involves HIV, HPV, SCV, syphilis, CMV screening, malaria screening, systemic function test, which involves ECG, liver function, renal function, thyroid, biochemical parameters, transfusion medicine, donor and patients, blood group antibody screen, as well as if there is incompatibility, the titers, the baseline titers are important. And then the counts and coagulation test in imaging, X-ray and ultrasound. These are important tests which has to be done in all the before the stem cell collection. Important that all these testings are done to understand whether how it will affect the collection and the outcome of patients, as the HLA mismatch can increase the risk of GVHD. So mostly in related donors, full match donors are preferred. If there is a history of prior blood transfusion, it may increase the graft rejection risk, or if the patient has DAC antibodies. If the patient has multiple donors, younger donors are younger age is favorable. Where in gender actually mismatch, female donor to male recipient is not preferred. And for recipients, sibling donors are preferred. The seropositivity in CMV positive donors to negative are not preferred. And nowadays in HLA, there are multiple components are seen. So even the NK cell reactivity in form of K typing. So there are multiple things which are checked to just to see whether these are the risk factors and which can affect the outcome. And for that, we require to have a process how to do it. So how we follow this form where the patient's history, the physical examination, the laboratory tests are documented here, and the venous veins are assessed, and the donor is counseled for the donation as well as for the blood replacement. And then the consent is taken from the donor as well as the family if the donor is a pediatric. Again, the informed consent is very important, where it is mentioned that about the method of the procedure, about anticoagulants given, if the collection can be 1 day or 2 days collection, and about venous access, what are the possible risks and complications and management, and the consents are taken. It is important that pediatric donors are not small adults. So usually there is no benefit for pediatrics. So as per the American Academy of Pediatrics, they say that until there is no adult relative is available, then only pediatric donors should be sought. And definitely there should be a good personal and emotionally positive relationship between the donor and recipient when we are dealing with a pediatric donor. And the chances of benefit of the recipient from transplant should be good, as if there is a loss, there might be an emotional and psychosocial risk to the donors. And definitely the both family and the patient and parents should be counseled, and their permission should be taken when we are going for pediatric stem cell collection. So mostly 1 day prior, we again look for that we are going for peripheral or central lines. HLA match is very important, because if it is a haploidentical, we definitely may require a higher dose. Patient and donor weights may differ, so which decides how much we are going to process. Pediatric donors who are less than 25 kgs, custom prime is required. So for that, we have to plan a day ahead in form of reserving a cross-match compatible irradiated leukodepleted red cells. And again, to plan for whether there is incompatible, the baseline titers, need for plasma reduction or red cell reduction, requirement of cryopreservation. So these all preparations actually start a week prior to a day before. In case of haploidentical donors, as the number of cases are increasing, many times parents or siblings or first degree relatives who are a haplotype match or a half match may be the donors. Again, in these patients, usually in pediatric population, the dose of stem cells or CD34 is required is 10 millions per kg as in our center. So we need to plan ahead. Many times these patients, for example, in thalassemia, The donors are trade donors. They will have low MCV, and here we may have microcytic, they may have microcytic anemia, so we need to check their counts, and we may have to plan higher collection, especially in those donors when we are going for thalassemia transplants. And again, if there is a mismatch, the possibility of HLA antibodies are there, we need to check. And many of these haploidentical cases are going for this high dose infusions with post-transplant cyclophosphamide. But if the patients are smaller, less than 10 kgs, they may go for a post-processing of stem cells. For example, alpha beta T cell depletion or CD34 enrichment and cryopreservation. So all these plannings or protocol has to be discussed in pediatric transplants before the actual collection day. So if we talk about mobilization, we all are aware that 4 to 5 days GCSF is usually given, and on 5th day we collect. So in studies, they have shown that single dose of GCSF 10 mg per kg per day is optimal for efficient collection in pediatric population also. And also there are cases where both plerixafor and filgrastim can be used together if there is a requirement of higher dose. And for autologous cases, again, the use of chemotherapy where cyclophosphamide along with GCSF is used. And adverse effects can be there, but it is seen in children, usually bone pains, and the pains are usually less commonly found. But yes, adverse effects has to be seen in these pediatric donors also. So again, there may be poor mobilizers, patients who have lower counts. In autologous cases, patients with advanced ages or having some comorbidities or with prior chemo or radiotherapy, there are various risk factors where we can predict that there will be poor mobilization and can plan for plerixafor, and with pre-CD34 count, we can analyze for the collections. Similarly, for the healthy donors also, it can be predicted. Usually it is seen in this study that usually male gender, younger age, and good weight difference helps in better CD34 yield, as well as donors who have low MCVs, less than 80, mostly in, as I said, thalassemia traits. There the harvest has a low count, so definitely more mobilization is required in such donors. So after mobilization, collection, as we all are aware, requires multiple things: vascular access, how we are collecting, what instrument we are using, anticoagulation, custom priming requirement, the pre-medications, and the monitoring of the procedure, and how much to collect. In pediatric population, there are main 3 aspects which are important. That is, usually the vascular access is important. So in which cases we can go for central, or whether they are peripheral can be collected is important. Anticoagulation in pediatric, because they're at risk of hypocalcemia, should be carefully checked because they are low volume, they are having more chances of hemodynamic instability, and for that, when we are using apheresis machine, we have to monitor the extracorporeal volume and, if required, custom prime. Again, one important thing is psychosocial aspect, where when we are dealing with small pediatric donors, need to have a patience, and for that the nursing staff plays very important role. Many times we require the parents to be there along with them to various distraction in form of the cartoon movies or some kind of interactions which can help them. And many times mild sedation may be required for for smaller pediatric stem cell donors who are anxious or non-cooperative. So vascular access, actually in our center, if a donor is below 10 to 12 years or less than 25 the weight is less than 30 kgs, usually we ask for central vein. And during consultation, it is given in a written form so that the plan can be timely done for CVC positioning. And it is done usually ultrasound guided. And after that, it is cross-verified by X-ray. So usually whoever is doing, they should have appropriate understanding that what is the requirement of apheresis, what is the flow rates required, and what lumen is required. So usually double lumen we ask for a good flow. Definitely we have to ensure that there is no disturbance in flow, because it disturbs the interfacing and there might be a contamination of red cell and neutrophils during procedure. So a good vascular access is actually the most important aspect, and it has to be decided before during planning. Coming to the instruments, there are multiple instruments available. It can be discontinuous or continuous. Usually it is both double needle, so that we have 2 axes, inlet and return. We usually look for instruments with smaller extracorporeal volume, which can be moved and having a computer controlled systems where we enter the values and it has controls there, and which has lower cross contamination, and the final product can be we can do it on pediatric with less of loss of platelets and cells. So these are the different instruments. For pediatric population, total blood volume and extracorporeal circuit volume is very important aspect. In donors who are usually 3 months or older, we calculate by 65 to 75 ml per kg. And it is important to know that extracorporeal volume should be less than 15% of total blood volume. So this calculation is important. If we enter the data, usually in Optia, if you're using Optia, if it is patient donor is less than 25 kgs, we have to manually enter it. And it shows whether there is a requirement of custom prime if extracorporeal is more than 15%. And it also shows that what will be the patient hematocrit if we are not doing custom prime. So we can see the fall of hematocrit, or if the patient will have intra-procedural no chances of anemia or hypoxia. So we can see that if there is a significant fall, we can decide based on patient's weight as well as the patient's hematocrit. So ideally, custom prime is planned when weight is less than 25 kgs or total blood volume is less than 1800 ml. Extracorporeal volume for each instrument is different. So say, for example, for Optia, for CMNC collection, it is using ideal filler is 253, and which can go up to 297. So we can take that as extracorporeal volume for the calculation and see that if the patients or the donors are having the extracorporeal volume less than or more than 15%, or safer side 10% we can keep. Coming to anticoagulation, most of the places ACD-A is the anticoagulant which is used for apheresis, and usually in the form of 1:12 ratio, and which can be increased further. And common signs of hypocalcemia like nausea, vomiting, tingling, sensations, pallor, paresthesia, rhythm alterations can be there, but sometimes in low weight donors, it can be just abdominal pain or restlessness, which can be the first symptom. So very important is monitoring that these small donors should be having a continuous monitoring of ECG and blood pressure, these every 15 minutes. And a baseline VBG helps to understand ionized calcium and magnesium levels. Usually prophylactic calcium gluconate 10% is given to all the donors, and the dose can be adjusted. For example, for smaller donors, 3 to 5 ml per hour in dilution can be given as a continuous infusions. There are certain centers who are using heparin along with ACD, with the higher ACD ratio to prevent separate toxicity. But as of now, I don't have experience on that. So as I said, for a procedure, it is important that we do close monitoring for vitals every 15 minutes for blood pressure, heart rate, and temperature. Calcium supplement usually should be given. And mostly we do pre-medication in form of giving MCIT and PAN injections, so that many times patients may have episodes of vomiting or epigastric pain or acidity. So usually we see that pre-medications in our center we follow giving it to all patients. And it is important to see the signs of citrate reactions and to titrate the calcium supplement based on that. Collection preference, it is very important that when we are collecting stem cells, usually we are monitoring the buffy coat layer, and there, based on this color or collection preference, we can actually adjust based on the requirement of patient. Say for ABO incompatible transplants where we need to reduce the red cells, we can be on the higher side so that the red cell contamination is less, and it can also help in reducing the platelet loss in more platelets on product, or in the yield of the product by going deeper in this interface. So this can be adjusted, and usually we keep it between 30 to 50. Coming to the goals of collection, the target dose usually is 3 to 8 million per kg. In haploidentical cases, usually 10 million up to 10 million cells per kg can be asked. And if there is a plan for post-processing, many times 20 million, because there may be a loss of cells during processing, or for alpha beta and CD45 RA cell depletion, they ask for high dose. Definitely, higher is the dose, that it improves the engraftment of platelet and WBCs, as well as for the manipulations. It is important that we should know the collection efficiency of our instrument. We can do it by calculating every procedure, that how much cells are collected divided by the average of pre and post apheresis CD34 into the total blood processed minus ACD volume. So usually it can be somewhere between 30 to 70%. And if you are aware about your equipment's collection efficiency, you can actually predict that how much you should volume you should process for the next procedures. So, for example, if a machine has, say, for our Optia, if the collection efficiency is 50%, and a recipient whose weight is 20 kgs, and the donor is father with 60 kgs, so how much we should process for this collection if the pre-count is, for example, 120, CD34 is 120 per microliter. So usually how we calculate is, we calculate the 3 blood volumes of the patient. Say for, in this case, 20 kgs, there will be 3 blood volumes will be around 4 liters. So we see that estimated yield will be pre-CD34 count 120 into collection efficiency 0.5 multiplied by 4 liters. So 4 divided by 20, which is patient's weight. So it gives an estimate that 12 millions per kg can be collected. So actually in this, we need not to go for 2 or 3 volume collection, and we can get the estimated or the required dose in only 1 blood volume processing. So this prediction of dose and volume helps actually, especially in our center, where many times the donor is parents and the pediatrics, there's a small patient, so we can do less processing and reduce the wastage of stem cells. Again, after processing, it is very important that this finished product requires the processing in form of doing volume reduction or any manipulation, say CD34 selection or any tumor purging. Similarly, for allogenic cases, if there is ABO incompatibility, do we require any plasma reduction or any red cell reduction, or further requires any immunomagnetic sorting? So because nowadays in haploidentical cases, there are many times the procedures are happening where post-collection alpha beta depletion will be happening. So in these cases, after doing the collection, these products, they label the CD45 RA and alpha beta with the antibodies, and then it is passed through this machine called Clinimax Plus, or there is a fully automation Prodigy, and in which there is usually a magnet which holds these binded or labeled cells, and the remaining cells goes, so it can help in the negative selection as well as for positive selection. If we want to do for CD34 positive cells, we want to extract, And this method can be used for for the cells sorting and for the patients. Definitely, many times allogenic, we are doing it at the same time. So we collect and give it to the patient same time. But whenever the patients are not ready, or in the cases of autologous transplants, we may require cryopreservation. So it is definitely a important role of transfusion medicine to have this facility either in the form of -80 or using liquid nitrogen. And then cryopreservation methods and all are important. And definitely it is important that we have a facility where we can do it in sterile conditions, and when we are thawing it, it should be having maintaining the quality as well as the sterility. So for product quality, we follow with the product MNC counts, platelet and hematocrit, CD34 count. And again, the viability test is checked during the collection as well as before infusion. Sterility test we do before cryopreservation as well as after adding the MSO, we check for sterility. It is important that whenever we are thawing the cryopreserved product, it should be done in a faster manner so that the DMSO, which is added as a cryoprotective agent, it is toxic. So it should be done, mostly we do it in blood bank, but it can be done bedside. So facility has to be there, and thawing can be done. The product should be given faster, say 10 to 15 ml per minute. And it should be ensured that we calculate the dose and DMSO content so that usually if it is more than 1 gram DMSO per kg, we should give it in a divided dose, say over 2 consecutive days. And again, it is nephrotoxic, so the symptoms for toxicity should be seen. And if it is definitely a higher dose, we should also think for options, say for washing of DMSO before giving. Coming to another aspect is ABO incompatible. We all are aware that donor and patients may have different blood groups as they are not present on stem cells. Usually it does not affect the outcome of the patient, this incompatibility, but it requires a close monitoring. So we all know that compatible, major incompatible, where the patient has antibodies, minor where the donor has antibodies against the recipient antigens. So in these stem cell transplants, there are problems which may happen if in form of hemolytic reactions or delayed engraftment, or form of red cell aplasia. In minor ABO incompatible, there might be possibility of passenger lymphocyte syndromes. So it is important that when we are planning for transplant, we look for whether it is a major or minor incompatibility. And in those cases, we should go for the titers of patient or donor. And based on that, we need to check whether we need any processing or any plasmapheresis to remove the antibodies. So in cases of major ABO incompatible, if titers are higher than 32, then only usually we plan. Otherwise, mostly we reduce the red cell content in the product. Nowadays, the instruments are good where we can reduce the hematocrit of the product by monitoring the color of the product. Only if the titers are very high, we need to go for titer depletion in the patient. While in minor ABO incompatible, if the titers are higher or more than 256, we can do plasma depletion, and then we can give it to the patient with plasma depletion. So in our center, we have 106 patients where mostly allogenic cases we are doing, where MASH-related donors 46 and haplos 38. Surprisingly, in MASH-related donors also, we had 13 fathers, 7 mothers, and siblings 25 and 1 uncle. And we have also done MASH-unrelated donors 18 procedures, where we received the products from the registry collections, and we cryopreserve and give it to patients when they are ready. Overall, we had 26 donors were pediatric and adult donors were 58. If we see the comparison, usually whenever there are pediatric donors, the average weight is 34 kgs, which ranges from 12.5 to 80 kgs, and the pediatric donor range from 3 to 17 years. And again, the total blood volume process can range from 1 volume to 4. Can go up to higher volume of 4.4. And out of 26 pediatric donors, 10 patients required custom prime, and 2 patients we did on peripheral in pediatric donors, while in adult donors, 39 were performed on peripheral access. And in pediatric donors, 3 cases where we required a second-day collection because of poor mobilization and less collection on day 1s. Again, if you see the haploidentical and match related donors, mostly haploidenticals were parents or parents, so definitely the doses were higher. But these cases, patients had higher red cell requirement and platelet requirements, and the post-operative, also post-BMT complications are slightly higher compared to match-related donors. You see the blood group incompatibility, 71 cases were ABO identical, 7 were RH incompatible, where patients were RH negative and the donors were RH positive. Major incompatible were 15 and minors 17, and bidirectional were 3. So with this, I'll just close with 2 cases. First case is ABO incompatible bone marrow transplant and thalassemia major with match related donor. So this child was 3, a female. She was O positive with a titer of 64 and 128. And donor was brother, was 10 years, B positive and full match. So in this case, because the titers were high, the plasma exchange was planned before the transplant, and it was 1 volume plasmapheresis was done with the custom prime, as the hemoglobin was low and weight was 10 kgs. So post TP, the titer reduced from 64, 1 and 28 to 8 and 32. And then the PBSC collection was done. 80 ml collection was done here from the brother, and in which we actually gave 35 ml, which was around 12 million per kgs with hematocrit 5.2. So usually in pediatric, in adult, we say overall up to 20 ml of red cell contamination is permissible, where there is no need for depletion of red cells. But in pediatric, usually 0.4 ml per kg is acceptable. So in this case, it was 1.82 ml in the product, which was transfused to the patient. So this patient, this was the follow-up was done. So post-operative, there was not much fall of titer. So again, on day 7, IVIG was given for 2 days, 1 gram per kg. And then it showed the fall of titers. And again, the engraftment of neutrophil engraftment on day 12 and platelet on day 15, it was noted. And on day 17, patient was discharged. So again, red cell engraftment takes time, especially if antibodies are not disappearing. And this patient at day 60, it was showing a mixed field kind of picture. Still, it was not fully engrafted. And then on day 87, it showed the complete donor B positive. So we may see a delayed engraftment in patients with major ABO incompatible. One more case, this patient had thalassemia major with O negative blood group, and here in antibody screening, the patient was showing anti-D and anti-C antibodies. Patient hemoglobin was 10.3. Here the donor was father, haplomatch, and 28 years, O positive, with both the antigen positive. That means D and capital C both were positive. And this patient had DSA positive also. So this was a case of haploidentical BMT with HLA aluminization as well as red cell aluminization with the NTDNC. So in this case, we, as a protocol in our hospital, we did 2 cycles of PPE and followed that patient underwent, we went for the collection from donor. And here the donor was given plerixafor and we collected around 1.6 volume was processed. And as I said, we used the pre-count, and based on pre-count with the lower efficiency, because it was a trait, we predicted 15 million, and with the plan of red cell reduction, because it was O negative donor with O positive donor, and the recipient was O negative. So we collected around 180 ml, and which was around 18.6 million per kg CD34 and 6 into 10 power 8 kg CD3. So it is also important that in haploidenticals, we monitor CD34 as well as CD3 to see that how much T cell dose we are giving. And usually we try to contain it to 3 to 5 into 10 power 8 per kg and not more than that. So the product was given around 9 million cells, CD34, and 3 into 10 power 8, and hematocrit was kept less than 3%. So in this case, if we see a pre-transplant patient had DSA and NTDNC, and which remained up to post BMT day 7, and after that started reducing. Day 38, the antibodies disappeared, and you see here, this was day 38. Still, we couldn't see any engraftment, but yes, day 60 recently, we have seen that now there is O positive, and the C antigen also is engraftment. So this patient has WBC engraftment on day 17, platelet on 31. There was a delayed engraftment here, and red cell engraftment also. I think it is not fully engrafted. Yes, patient was discharged with hemoglobin 12, WBCs 5,430, and platelet 20,000. So lastly, we do have a challenge of many times these patients may have HLA antibodies. So in our center, 5 patients with DSA antibodies who patients who underwent haploidentical transplants. There is a protocol of 3 procedures of PPE on day -16, -14, and -12, followed by IVIG and rituximab. And these patients, out of 3 patients had engraftments, and 12-month survival was 80%. 1 patient had primary graft failure, and that autologous collected cells were given back, and rescue cells were given, while 1 patient expired. In spite of improvement in titers, it expired due to sepsis. So with this, I would like to conclude that in stem cell transplant sites, there are a lot of advancements happening with improvement in HLA typings, unrelated donor registries like DA3, DKMS, Marrow Donor Registry India, and international registries. The number of haploidentical transplants are increasing with better GVHD prophylaxis and conditioning regimens. And this whole modality is expanding for various clinical indications. It definitely requires a important team effort and coordination for successful outcome in this program. Transfusion medicine plays an important role for donor management, for collection, processing, manipulations, preservation of product. Many of the centers who are dealing with HLA laboratory, immunohematology laboratory, specialized component support with modifications, therapeutic apheresis, and recently with the CAR T-cell therapies. So definitely there are multiple advancements are happening, and transfusion medicine play a very important role in transplant programs. Thank you. Would be happy to take the questions now.
Thank you, madam. Thank you for this wonderful session. So the session is open for questions. So we have a question in the chat box. Is there any prediction formula based on mono plus lympho percentage counts from ADVIA instead of CD34? Sometimes clinicians don't want to burden the patient for pre-procedure additional cost of CD34. The question was asked from Dr. Deep. I think he's reading cell counters value. Please carry on.
Right. So initially we were trying with definitely this mononuclear counts, but many times what we see that what we get from the five-part analyzers, they're actually not very good predictive, but yes, we can calculate similar to how we calculate CD34, but definitely we initially found that until unless it is a microscopically checked percentage, it doesn't correlate well. So we can have a close idea by seeing the MNC percentage, how much is the pre-count, but I have not tried any formula for no prediction of adequate dose using MNC. But I think if we can use the similar formula and try, it might give you somewhat similar idea that collection is sufficient or not, but I have personally not checked. We usually get a pre-MNC percentage and count, and we calculate after collection also, but prediction part, definitely I'm not sure if it can be done same as, because collection efficiency is actually standardized or validated for CD34. So we need to validate first for that, and then we can come up with the formula for collection efficiency. Dr. Mohan, if you have some idea, you can you can guide.
I'm not sure with the ADVIA's count. There is a system called Sysmax. It has a model called they have a module called HPC count.
Okay.
So it's a 7-part cell counter, which has a function for estimating HPC count, which is actually a surrogate for CD34 count. Okay. I'm not sure about the other cell counters. So there are a few publications from Medanta on this. So where they predicted CD34 count by using HPC count. So it can be done in a 7-part counter.
Okay.
So that is my limited information on that. So the other participants can unmute and ask queries directly to Dr. Deepthi. So, madam, I have a few questions for you.
Yes.
Where do you do the PBC collection in pediatric patients, donors or patients? In the blood bank or in the
what? So, we have actually a collection facility in blood center also, but for in-house pediatric collections, in our BMT unit, near the exit, we have a apheresis room, which we have made only for the collections, where we have kept one Optia and we use it as a collection room for, so it has all the monitor and all the facility there, and it is closer to the, where all the PHO team sits. So we as of now, we do pediatric collections in apheresis room closer to BMT unit, but the voluntary donors or the voluntary collections or adult collections, we have also started collecting in blood center. Mostly for voluntary donors who do not prefer to go in ICU settings, we do collect in blood center for their comfort. But we need to have all the facility for monitoring as well as emergency medications and important management should be there in blood center. We can do it in blood center.
My next question is, you mentioned about the DMS or dose actually, So we had given some values also. How will you plan your DMSO infusion, madam? In such cases, like if the dose exits, what is your plan?
So for whenever we have a cryopreservation plan, starting itself, we keep in mind the patient weight. So usually cryopreservations are not very long stored, mostly 15 days or a month storage. So firstly, when we when we preserve it, we calculate how much is the overall DMSO. For example, if it is 7.5% in the bag, we are preserving as a final concentration. That means in 100 ml, there is 7.5 grams. So per kg, we have to see, so that if it is say 15 kgs, so it is a 0.5 grams per kg. So up to 1 grams is allowed per kg. So we can calculate overall dose and see that if it is coming less than 1 or more. If it goes more than 1 gram per kg, we can divide it over 2 days infusion so that we can reduce the toxicity. And the best is to reduce the overall collection volume, so that when we overall the volume of the product is reduced, we can similarly the DMSO volume also reduces. So we actually keep it as a concentrated product with lesser DMSO, so that at the time of infusion, we don't have to go for washing of product. We can give it safely with the lesser DMSO. So that is what we practice at our center.
If time permits, shall I ask one more?
Yes, please.
Like you mentioned about the RBC content with respect to the recipient's titer. Like you had shared your IgM titer as well as IgG titer with respect to plasma exchange. You do.
Yes.
So in such cases, like generally speaking, you look at the IgM titers or IgG titers to determine whether the RBC, like any RBC manipulation has to be done with respect to all ABO incompatible transplant, not specifically pediatric.
So for all transplants, actually, if you talk about liver, kidney, or this also, we see both IgG and IgM. And what we say is IgG is more important as a titer. It may be more harmful, though the immediate hemolysis wise, we know that IgM is harmful, but overall, if you ask one antibody which we need to see, it will be IgG type of antibody. But in practice, I think most of the centers follow both IgM and IgG. Yes, when we say IgG, many times we are doing total if we are not doing DTT treatment. But yes, we should do ideally both IgM and IgG antibodies. And when we say critical or threshold titer, we want to bring both of them, say below 16 or below 32. We go for both antibodies to go down. Usually IgMs are easier to reduce because there are bigger molecules. And IgG in that case becomes critical to bring it down below the cutoff. Say for organ transplant, we say we have to bring it down below 16. So where we might require more cycles to bring IgG antibodies down below the critical level. But we follow both IgM and IgG.
Thank you, madam. Any questions from the participants?
Ma'am, I have one question, ma'am.
Yes,
Can
sir.
you give a further color on how RBC depletion and plasma reduction is done post-collection in your center?
Right. So whenever we have minor incompatible, usually we see the titers, say the donor titer. If titers are more than 128 or 256, we require plasma reduction. But considering many times we have donors as bigger, say the elder sibling or parents, we have higher volume products. So we have a practice of doing plasma reduction for all minor incompatible collections. For that, we need to have a set protocol in which, say we do it 300 G for 10 minutes at 4 degrees. We have a set protocol in centrifuge. So we connect a bag and we centrifuge And with this PBSC plasma depletion protocol, we have fixed in our blood bag centrifuge, and we do it. And we calculate, usually if we are doing plasma reduction, we should have the CD34 count prior, so that we know that the total dose will remain same, so that how much volume we are removing, we can, after that, calculation becomes easier about the dosing. So for example, if we have a 200 ml collection, after removing, say if we are removing 50% of plasma, the dose will remain same, but the volume will become half. For example, if you're reducing 200 ml. So we do calculate using the formula of say P1V1 is equal to P2V2, where the final how much we are reducing, so what will be the further concentration for dosing, or overall how much is in the bag. So plasma reduction we do in using the centrifuge, and red cell mostly we have till now we are able to reduce the hematocrit with the help of monitoring using Optia. So there by the color, if we go with the band, the first two, if we monitor, usually we can manage the hematocrit. In pediatric, actually 0.4 ml per kg is the acceptable range. So if you have, usually nowadays collections are having very less red cells, so can be managed by just monitoring the color and the final product. We need to see the hematocrit. Again, using hematocrit or using red cells, we can calculate the red cell contamination. So suppose if we are calculating hematocrit, we can calculate, say if the hematocrit is 2%, we can calculate, say out of 100 ml, there is 2 ml, or we can calculate by multiplying with the MCV. So that total red cell count into MCV we can calculate. So red cell contamination we finally calculate, it should be less than 20 ml in adults, and for pediatric it is 0.4 ml per kg. So we ensure that there's not too much of red cells. And again, for major incompatible, we also check recipient titer. So until unless it is not very high, we don't go for plasma exchange. By just controlling the red cells, we can go safely for the red cell, the product infusion without any risk for red cell depletion. Dr. Nitin, if
Thank you, ma'am. That was really helpful. That was really helpful.
Any questions from the audience, please? One last question from me.
Yes, Mohan.
Like if the donor is heavier than less heavier than the patient. So what I mean is, if the patient appears to be a heavier and the donor is tender, so
Yes.
how do you manage the procedural parameters, madam? Any special precautions to be taken during the procedure? Because we may end up in processing more blood volumes to attain the target yield, right?
Yes.
Like any modifications or any precautions we should mind during such procedures?
Yes, so definitely it's actually a very important question, that this donor recipient weight ratio, many times when donors are smaller, we definitely have to plan for higher collection. It may go usually we say we restrict to 3 volumes, but even for us, we have gone up to 4.5 volumes in a day. But many times, if it depends on donor, if we are already predicting that there will be count, we can usually it requires a discussion whether we can give plerixafor and get a sufficient collection in single day, or we can plan for a 2 days collection, so that on single day there is not too much of pressure on patient or the risk of adverse events in form of a lot of citrate exposure. So say in overall, we had 2 cases where first day we went up to 4 volume, but still we couldn't collect and we had to go for second day. So we thought in such scenarios where the donors are smaller, we should plan it like 2 days collection so that it remains safe and not to go beyond 3 volume on single day. And
Like, do you
yes.
practice Pleric in that setting, madam?
Sorry?
You practice Pleric giving Pleric for the donors in such setting?
Yes, yes. Many times Pediatric is given, and definitely the decision is taken by the PHO team, the pediatric hemato-oncology team, that for Plerixafor giving. But yes, for donors, they use Plerixafor when, especially in haploidentical cases where there is a higher need of a stem cell dose, they give Plerixafor on day 4. Yes, ma'am.
Thank you very much, madam, for enlightening us.
Thank you. And
Any more questions? Can we close this session otherwise? Rafi, are you available?
On behalf of TMAS, I thank Dr. Deepthi Sachin for this interesting session in your busy schedule and patiently answering to each and every query. I also thank Dr. Mohandos sir for sharing the session and for the informative questions and answer session as well. We will be meeting again on June 30th at 2 p.m. again for our monthly clinical club by Dr. Prithviraj and by Dr. Purushottam, chaired by Dr. Nitin Henry. Until then, bye.
thank you.